Hello and welcome to Dragonfly Ask the Experts. Today we have a very special seminar, webinar with two experts. The topic is community and self-care in academia, featuring Dr. George Everly Jr. and Dr. Neda Gould. This webinar is being recorded, and we are going to be posting this online. So we do want to begin by just introducing our experts. And today we're going to be hearing from Dr. George S. Everly Jr. He is the top-ranked published author in the world on the subject of psychological first aid, according to PubMed. He is the author of the Coursera online PFA course, which is linked in the video notes below and in the chat in the webinar. And this has hosted over 585,000 students. He is the author of the Johns Hopkins Guide to Psychological First Aid and the Johns Hopkins Guide to Everyday Psychological First Aid. Everly has also served on the faculties of Harvard University, the Johns Hopkins Bloomberg School of Public Health, and the Johns Hopkins School of Medicine. Dragonfly Mental Health, which I'll tell you a little bit about in just a moment, requires all of our Dragonfly ambassadors who present our programs to communities all over the world to complete this Coursera course in psychological first aid. And I actually just found out today that this is the 13th most viewed course in the history of the internet, according to Business Insider. Dr. Neda Gould will be addressing us second, and she is a clinical psychologist and associate professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine, where she is director of the Mindfulness program there. In addition to treating patients with anxiety and depression using cognitive behavioral therapy, one of her primary areas of interest is teaching mindfulness-based stress reduction and other mindfulness programs to patients, to faculty, and to staff to address stress and reduce burnout. Dr. Gould is a member of the Johns Hopkins Miller Colson Academy of Clinical Excellence. She lectures nationally and internationally on the benefits of mindfulness for well-being. Dragonfly Mental Health collaborated with Dr. Gould starting last summer in July, and we created a custom integrated and evidence-based 3-hour presentation for the NIH Biomedical Program Directors meeting held in Washington, D.C. I will take a few moments now to introduce Dragonfly Mental Health for those not familiar with us. So we are a 501c3 nonprofit. We're based in the US and we are serving people and communities and academics worldwide because our mission is to cultivate excellent mental health among academics worldwide. But we don't just want to address poor mental health. What we envision is a world where academics take care of their minds like elite athletes take care of their bodies, proactively and preventatively as a community and with deep forethought, so that they can perform at their highest level to the benefit of all humanity. At Dragonfly, we operate based on 7 core principles: kindness, active inclusion, open access, integrity, deliberate diversity, evidence-based, and sustainability. So today we are making this webinar fully available freely to everyone in support of many of our values, but especially our open access value. So who is Dragonfly? We are a global team of academics that created Dragonfly Mental Health back in April 2020. We have a wide variety of expertises, including those in neuroscience, mental health research, medicine, but many, many, many other disciplines as well, from astrophysics to the humanities, from masters in fine arts to architecture. And we now have over 450 academic volunteers from more than 45 countries contributing to our efforts and this revolution. What we do at Dragonfly is based off of what we call the Dragonfly framework. And this involves 5 domains for the pursuit of excellent mental health in academic communities. This involves establishing or improving wellness committees within academic departments or schools, to create and support peer networks and peer support, to provide skills workshops and also enhance mental health literacy through discussion and education, and finally to fight stigma. And the way that we do this is through 3 different ways. We provide discrete programs and now have over 10 talks, 5 workshops that we've delivered more than 400 of these in 38 countries to over 60,000 academics. We also have a comprehensive approach or set of programs that we've been piloting at UC Berkeley that involve activities in all 5 of these domains. We now are expanding those programs as well to others through module-based engagement, and we have a second pilot of a comprehensive program funded by the Zurich Foundation in Germany. Finally, we offer independent and expert consulting, and we also engage in collaborative and independent research. So right before I hand it over, I do want to highlight one way that you can get involved in Dragonfly this very year. On October 10th, 2025, we are going to be celebrating World Mental Health Day with an event we call Dragonfly Global Migration. So on this day, we are going to be delivering as many talks and programs as we possibly can to as many communities around the world in a single day. These programs are all going to be offered for free and will be supported by sponsorships. So if you would like to get involved in any way, such as hosting one of these programs at a host site, or you want to train to deliver these programs as a Dragonfly ambassador, or you would like to support these programs as a sponsor, please go to this website, dragonflymentalhealth.org/dragonfly-global-migration, and click on the links there and learn more. With that, I'm going to hand it over to Dr. George Everly, who will be telling us about his work and the history behind psychological first aid.
We have failed to provide universal mental health care in the United States. That's been a goal for quite some time, but we just can't quite seem to get there. So it seems to me that the continuation of past practices is a fool's errand. We've got to think outside the box. We've got to think non-traditional means of delivering psychological support at the individual and community levels. This biased opinion is shared, however, by the United Nations and the World Health Organization, that we need to think in non-traditional delivery systems. Simply training more psychologists, psychiatrists, and social workers is not going to prove sufficient. It's been estimated even today, in 2025, we are 250,000 psychological health providers short of what we need, and that gap is going to continue to grow. So we've got to do something different. What's different? So I'm going to provide you with a resource. It's an open access journal. You don't have to put in any identifying information or anything. It's called crisisjournal.org, one word, crisisjournal.org. And if you go and look under the index, under Everly, you'll find a paper about providing psychological services to communities that are rural, underserved, or hard to access. And a lot of what I say in that paper rests on the availability and viability of the program I'm going to talk to you about today, which is, very simply, psychological first aid. So let's talk a little bit more about that. I'm going to show you some pictures. I want you to think about the psychological consequences, the psychological concomitants that may be associated with these pictures. My orientation, if you've probably been able to deduce, is disaster mental health. My first disaster was 3 Mile Island, 1979, believe it or not. But after that, I was called ultimately to 39 countries on 6 continents to provide consultation service presentations associated with different types of disasters. I had the privilege of serving the royal family of Kuwait for 10 years after the first Gulf War, and thought that was going to be one of my more unique experiences. I was asked to provide psychological training for the mental health system in Kuwait. The number one admitting diagnosis after the first Gulf War was PTSD, but their doctors were unfamiliar with how to treat it. So I was asked to train their doctors on how to treat it, but ultimately was asked to facilitate the development and rebuilding of the entire mental health system for the country. So that was a unique experience. I ended my tenure April 1st of 2001 and thought that was something that was going to be very, very unique. Little did I know that September 11th would be right around the corner. The Twin Towers came down on Tuesday. I was in New York on Friday, and I was in Mayor Giuliani's office on Sunday. I ultimately spent a year working with the New York City Police Department and Columbia College of Physicians and Surgeons, developing programs primarily to serve first responders, especially the police department, of which there were 55,000 sworn officers. I later stayed and worked with the New Jersey State Police in capacity as clinical director of their disaster response unit. So a lot of what I say comes from the idea of not just helping people one at a time, but millions at a time. I'd like to show you a little infomercial of sorts. It's only 6 minutes.
You may already know that physical first aid is a universally applicable skill that everyone should learn. It can be applied by a friend, family member, coworker, even a frontline manager at the workplace. When applied well, it can reduce acute physical stress and even save a life. But what about acute psychological distress? Well, just as there is physical first aid, there is something known as psychological first aid. In fact, the editors of the prestigious magazine Scientific American have asserted that all people should be trained in psychological first aid. In this installment, we look at the international standard for assisting people in acute distress. Psychological first aid, or PFA for short, has been endorsed by the World Health Organization, the American Psychological and Psychiatric Associations, and the Red Cross. The online learning platform Coursera even offers a free 4 to 5 hour class on the Johns Hopkins model of psychological first aid, which is one of the most popular models of PFA in the world. During the COVID-19 pandemic of 2020 to 2021, it hosted over 300,000 learners and several million viewers. To learn more about psychological first aid, let's speak to Dr. George S. Everly Jr. He is the author of the book The Johns Hopkins Guide to Psychological First Aid and is considered one of the world's foremost authorities on PFA. So, what exactly is PFA?
Psychological first aid, or PFA for short, is a supportive and compassionate presence designed to reduce acute psychological distress and facilitate access to more advanced care or support if required. It's actually a form of psychological crisis intervention which any adult can learn to employ. Most individuals experiencing psychological distress in the midst of a crisis or following some stressful event are best supported without medication and do not require counseling or psychotherapy. Actually, research spanning over 100 years has shown PFA to be an effective supportive intervention. PFA does not involve diagnosis, nor does it involve treatment per se. PFA may be used in a wide variety of circumstances, including stressors of daily life, at home, at work, family problems, in cases of loss and grief, and even disasters. PFA can be especially useful at the workplace for managers and even client service professionals who have to deal with distressed clients or customers on a daily basis.
And what tips can you give on being psychologically supportive to a person dealing with a crisis?
First, in advance, get formal training in psychological first aid. I think that's essential. Do not merely hope for a verbal Hail Mary. Second, be a compassionate presence. Let the person know you're there to help as best you can. And if you can't help, that you'll do your best to find someone else who can. If the person's extremely agitated, brief de-escalation techniques should be employed. Listen non-judgmentally to the person's story. Let them vent. Remember to let the person tell their complete story. The story always consists of two elements: the situation, what happened, and the personal reactions to what happened. You should not be thinking of solutions until you hear and understand both. So to help with this, you might want to keep in mind the following questions and actions. So, you can ask, what happened? And then you can ask, what hurts? Which is just a colloquialism for asking a person to describe the emotional distress they're experiencing. Third, you can ask, how bad is it? And listen carefully for severity and degree of urgency. How much is this interfering with what they need to do? Fourth, ask what the worst part might be, or what they need most in that moment. Fifth, if the problem that precipitated the emotional distress can be solved or at least mitigated, then help the person make a plan. Resist the temptation to provide a quick fix, unless, of course, there really is such a thing. When problem solving, help the person separate the objective problem from their subjective emotional reaction to the problem. They may not always be able to control the event, but they can begin to control how they react to the situation or event. Sixth, if the problem cannot be solved or mitigated, focus on helping the person feel more in control of their reactions. Most people, even in crisis, really don't want to be rescued. What they want is help in rescuing themselves. So brainstorm methods to reduce acute distress. Make a plan. Ask what you can do in that moment to help. You can also ask what's helped them to cope in the past with emotional distress. You can even ask them what they might tell you if your roles were reversed. Questions can be far more powerful than direct suggestions in helping people feel re-empowered and back in control of their lives. It's okay to offer a few personal options for coping with distress, especially things you found helpful in the past. And seventh, remember, the most effective acute crisis-oriented interventions usually end with a plan. Ask what next steps the person can take to help themselves or gain further assistance if needed. Identify resources the person may have that's already available to them. And then, of course, make a plan.
A paper in the American Journal of Psychiatry stated that psychological support in the midst of a crisis should be provided in an empathetic and practical manner without compromising one's integrity or psychological well-being. The science of psychological first aid may be a means to that end.
So let's talk a little bit about how we got to where we are. And Santayana is famous for saying those who fail to read history are doomed to repeat it. And unfortunately, there are a number of examples of people reinventing the wheel, and we don't want to do that. So let's start with a simple definition of what psychological first aid. We can consider it a compassionate and supportive presence designed to stabilize, mitigate, and I'll add facilitate access to continued care. So stabilize acute distress, mitigate acute distress, and in some instances, facilitating access to continued care, whatever that might be. So think of it this way. As physical first aid is to the practice of medicine, psychological first aid is the practice of psychotherapy. As every home, hopefully, would have a physical first aid kit, I would submit every home should have a everyday psychological first aid kit. So where does this fall on the idea of continuum of care, continuity of care? So if you look on the left, you'll see physical first aid, then basic life support, advanced life support, and then medicine and surgery moving left to right on our arrow. If you look above that, however, you'll see psychological first aid, crisis intervention. Psych first aid is a subset of crisis intervention, counseling, and then psychotropic medications and psychotherapy. As you see from this quote, even in 2013, PFA was the first and most favored early intervention approach. So what are our goals? Just to reiterate, stabilize, mitigate, facilitate, but let's add a fourth, and that is fostering hope. Most dangerous person on the planet is the person who has lost hope. Part of our job in psychological first aid is, as the video indicated, not to solve problems necessarily, not to solve long-standing issues with psychological functioning or mental health, but rather it is to engender hope. We have some core principles that I'd like to communicate. One is the 15-minute rule. The 15-minute rule, very simply said, is assume you only have 15 minutes to do a psychological first aid contact. If you do that, then you'll notice that it's imperative to choose your words carefully and remain task-focused. The 3 contact rule. There are several studies that suggest that 2 contacts are better than 1 in a first aid context. 3 contacts are actually better than 2 when possible. There's some research that suggests perhaps 4 and 5, but we're gonna call it the 3 contact rule, just from a practicality standpoint. The average contact probably lasts anywhere from 18 to 20 minutes. What is the wait principle? Why am I talking? Why am I talking? Wait. Before we say something, sometimes it's prudent to say, where is this likely to go? Am I about to open a door I can't close? Remember, as tempting as it is, it's not about us. Sometimes we will work with people and we have shared similar experiences. There's almost this reflexive inclination to say, well, when I had this problem, this is what I did. And let's reflect back on Aristotle. One of the biggest mistakes that I see being made is people actually get in arguments with people in psychological first aid. It still takes my breath away. So we're going to say, remember, don't argue. So think of it this way. It's a life preserver. It's not a boat. It is a Band-Aid. It's not surgery. So where'd it come from? Believe it or not, most of what we know, we've learned from World War I. And it was very clear that the standard psychiatric interventions for what was then called shell shock were failing. Only 5 to 15% of people returned to duty. So when they decided to move the interventions within the sound of the artillery, which was usually the most forward field hospitals, and people were instructed they would get 3 hot meals, a dry cot to sleep on, but they were to keep their rifles ready because they were forward, there was a chance that they would be called upon to defend the hospital, and in which case somewhere between 60 and 70% returned to combat in a very short period of time. If we reflect back, and I believe the citation is 1950 or around 1965, Lydia Thorne said that learning psychotherapy is one core skill for the psychologist or psychiatrist, but they are inadequately trained, she would say, if they did not learn the fundamentals of psychological first aid. So she proposed that providing reassurance, providing suggestions for action, allowing catharsis, and sometimes even using persuasive techniques, action directives, giving advice, and other supported methods could be used in a short-term context. In all disasters, whether they result from forces of nature or from enemy attack, the people involved are subjected to stresses of severity and quality not generally encountered. It's therefore vital for all disaster workers, not just the mental health corps, all disaster workers to have some familiarity with stress and how people can cope. And please take a note at the date on that, 1954. There are numerous models of psychological first aid out there. Very few are evidence-based. But if I look at from the macro level and we say, well, what do they really consist of? They generally listen to people, allow cathartic ventilation, protect them, provide safety as possible, and connect them with other resources. However, being initially trained in public health, where at the Johns Hopkins School, our motto is promoting health, saving lives, millions at a time, it was very clear that the connect part had some problems. We viewed the notion, especially in a disaster, of simply allowing catharsis and then hooking them up with mental health care as metaphorically kicking the can down the road. And what do you do in disasters when there is no 911? When the hospital is on fire or underwater, what do you do? What do you do in underserved, hard to access areas? What do you do? You've got to do something. So that's where we pioneered the mitigation aspect. Listen, protect, mitigate. Is there anything I can do in this moment to keep things from getting worse? Is there anything I can do in this moment to make things a little better without falling prey to the solving a complex problem with a simplistic solution failure? And always using the connect to other resources, but bringing into the fold resources that we don't typically think of, such as friends, family, coworkers, and perhaps community-trained volunteers. Since the 1970s, we've seen the rise of a concept that we will call peer support. So who is a peer in a community? Teachers could be excellent peers, public health professionals, people working in primary care physicians' offices. And how about this one? How about faith-based resources? When I was working in New York with the Red Cross, we did a survey and we asked people, given disasters such as this, where do you feel most comfortable going to seek psychological support? Number one was the faith-based community. Number two was primary medical providers. Number three was the mental health community. But if we are going to engage and utilize the first two on that list, some form of training is requisite. And the answer is not sending them to mental health school per se, but rather training in psychological first aid is what I would offer. So the Johns Hopkins model is a 5-step model. There are other variations on the model, but recognizing at the time there were no randomized controlled trials on psychological first aid. In fact, one Cochrane review and another review commissioned by the American Red Cross said quite frankly, there is no evidence to support the use of psychological first aid that falls in the area of randomized controlled trials, although both reports recommended the pursuit of PFA nevertheless. Probably the first time in history that the Cochrane Review has recommended something without substantial evidence for the practice. So we decided to conduct 2 randomized controlled trials. And we found that our model was effective at reducing acute anxiety, seeming to address acute depressed mood and engender hope. So not to get too research oriented, but I wanted to show you this slide because it tells an interesting story. It tells you that you have a treatment group and you have a control group. Now, the control group was basically an active listening group. So it was not doing nothing. So it's based on catharsis. And the treatment group was the 5-step model that we created. You'll see both groups start off as baseline at the same, but then you'll note a phenomenon. Both groups went up in terms of adverse mood. They were, in other words, simply said, the intervention seemed to be associated with increased acute distress. If you ended the study there, you would conclude that psychological first aid should be discontinued because it hurts people. But what we did is we sat people down and we left them alone and we said, think about what we've just talked about and I'll be back in 30 minutes. So we came back and we saw a declination in both groups, but you'll notice that the control group didn't quite go back to baseline, but the intervention group went back to baseline and beyond, and that is the therapeutic effect. The effect size was about a 0.4. We did the same thing with anxiety, and you see a very similar outcome. One thing that no other study that we read measured was hope. And what we saw in our condition was the psychological first aid engendered hope, whereas the traditional cathartic ventilation did not. I'll show you this slide. So we got a group of clergy who were interested in faith-based leadership. They were interested in learning psychological first aid skills. So we put them through a 3-day training program. And we then followed up with them a year later. And we were admittedly somewhat surprised to find that their resilience scores increased, their compassion fatigue scores decreased rather substantially. And you'll see that the effect size is 0.9 and 0.7, both indicative of large effect sizes. What this slide is telling us is that participating in training in and of itself appears to endow the participants with some sort of personal resilience as well. And this study has been replicated. So in sum, from a research point of view, what do we know about PFA? We know over the course of 2 randomized controlled trials and several community-based quasi-experimental designs that it improves knowledge about stress and disaster. It improves confidence at helping others. It improves one's feeling of being prepared. It improves triage skills, being able to distinguish mild from severe psychological injuries. It improves inclinations at the community level for collaboration between community organizations. It improves perceptions of personal resilience, reduces anxiety, reduces affective distress, and increases hope. Next question you might ask is, yes, but how long does this last? The longest longitudinal study of which I am aware showed that these effects lasted 20 years or more. And I think I am out of time. What I would simply say is psychological first aid is but one tool in a tool chest. It is not the answer to all problems. It is not a substitute for psychotherapy. But it is something that in times of the shortage of mental health providers, which is only going to get worse, in times when the world seems to be getting more stressful, not less. In fact, the World Health Organization tells us disasters are increasing rather dramatically. I reflect on something that Winston Churchill said. He said, there comes a time in everyone's life when we are called upon to do something extraordinary, to help another human being. What a shame it would be if we are not prepared when destiny taps us on the shoulder, for that could have been our finest hour. These processes, these psychological first aid processes, are ultimately designed to foster resilience and foster empowerment, self-empowerment. It's been said that people look outside themselves dream, but those who look inside themselves awaken. And I think therein resides where most resilience starts. Thank you.
Thank you so very much. That was a wonderful, wonderful first half of this seminar piece. Let's just hand it over straight to Dr. Gould because we want to get to Q&A. But thank you so very much, Dr. Everly, and we will have time for questions at the end as well. So we'll see that.
Yes, I can truncate some of my Wendy, because I'm sure there'll be lots of important questions. Thank you so much for having me here. It's really an honor. Dr. Everly, that was absolutely incredible. I'm a huge fan of everything you've done in your experiences, and I think you kind of set it up really nicely in terms of the transition to what I'm going to talk about in a moment is mindfulness for stress reduction, and that it's another tool you can add into your toolbox. It's another way that you can begin to build resilience, and perhaps in a slightly different mechanism, but there's a lot of kind of overlap, and perhaps we can talk more about that in the Q&A. So let me share my screen. So I'm not going to talk too much about the human stress response or the fight or flight response, fight, flee, or freeze response, but except just to say that this is a system that's in place that is very adaptive. It keeps us alive. It protects us in the face of danger. And at the same time, as humans, can become a chronic issue because we have the ability to turn this system on even following the termination of a stressor, because we have this ability to think and ruminate, and that can turn on the stress response even when in the absence of a stressor, and the brain doesn't distinguish between that actual and perceived threat at times. And so then we're left with this chronic stress. And we all know chronic stress. We know about the impact, the negative impact that it's associated with a lot of psychological and physical symptoms that are unhelpful. This is a really fascinating book. Some of you may have read it. Essentially, the premise behind it is, why don't zebras get ulcers? Because just like other animals, when the stressor is gone, they are able to return back to homeostasis. But as I mentioned, with us, we continue to think about it. We continue to think about those traumas. And I'm hoping that you all have tools to cope with stress, including some of the wonderful PFA resources that that Dr. Everly shared, I'm going to talk a little bit about mindfulness. And this is something that's really near and dear to my heart, and something that I was introduced to as a postdoc and was really life-changing and powerful for me, this concept of living in the present moment, which I had never actually thought about doing. It was not in my repertoire of skills. I was always thinking about the future or the past, and it made me very productive, but also at times a little bit miserable. So this concept was really earth-shattering for me, of paying attention on purpose in the present moment, non-judgmentally. So thinking about it another way, that we're paying attention to what's happening inside our bodies and outside with a particular attitude, and I'll talk about that attitude moment, and with a particular intention of non-judgmental awareness. And I won't go through all of these, but the foundations of this practice are to be non-judgmental, as I mentioned. So instead of, I like this, I don't like this, we're beginning to turn towards experiences that are here. We're beginning to accept what's present, even if we like it or don't like it, and begin to explore what's here. And this is a muscle that needs to be built. And in the context of some of the traumas that Dr. Everly described, the skill is to know how to come to terms with some of those things in the moment. And so this is kind of a muscle that you build and then learn the art of, okay, what do I need in this moment? And I'd love to at some point talk more with Dr. Everly about kind of his thoughts about the integration of these two things, because I think it's really, really fascinating. And most of us spend a lot of our times in this state of autopilot. So we're going through motions, but we're not fully present. And so driving is one that comes up a lot for people, which is kind of terrifying if you think about it, that everyone on the road is mindless. But you might think of some examples in your own life. And so there are a lot of factors that get in the way of our ability to be fully present in this moment. And these are just some. I mentioned thinking. So we have the ability to think about the future, to worry, to get caught up in these stories that may or may not ever happen. Our tendency to multitask, which we think we're great at, but we actually aren't great at it. And then, of course, cell phones. So an instantaneous way to get pulled away from the present moment, sometimes into perhaps pleasant things, and sometimes not. And so this idea of mindfulness, when can we practice it? Theoretically, in every moment. Most of us aren't going to become Buddhist monks or nuns and have that as our life intention. But in theory, we can bring mindfulness to every moment. So, and there are two ways. So people often think of mindfulness as someone sitting down and meditating, and that's what we call formal mindfulness practice. So using an anchor to bring attention to the present moment. And if there are no questions at the end, and Wendy approves, I'm happy to guide us through a brief one, but I suspect that we'll have plenty of discussion. And then informally, noticing when you're in that autopilot mode and bringing awareness back to the present moment. A couple of myths. A lot of people who come through my courses will say, oh, I can't meditate. I can't empty my mind of thoughts. Well, either can I. That's not the goal of the meditation. The idea is to begin to notice our thoughts without getting swept away in them, but being aware of them, as opposed to trying to get rid of them or push them away. And that I should feel relaxed afterwards. So that this is the mindfulness practices are overlapping but distinct from relaxation practices where you might do something to feel different. Here we are noticing our experience without necessarily trying to change it. And that's how it's a little different. And so if you're feeling tension, if you're feeling anxiety, we note that, we label that, as opposed to how do I get rid of this in this moment right now. And people often say, I'll be less productive if I'm focused on the present, or I don't have time to take this chunk of time to meditate. But it turns out what we see from the research is that people are actually more productive if you do take some time each day to recenter and refocus using these skills. So what are some additional benefits of mindfulness meditation? Well, there are a lot. This is an area of research that's just exploded over the past several years in terms of the benefits. And what we see consistently across clinical and non-clinical populations is this decrease in stress, anxiety, depression. Very consistently, we see decreases also in pain severity, disability associated with pain and pain acceptance. We also see that our brain changes as a result of these practices. And actually, anytime we learn something new, we're creating new pathways in the brain. But I'll talk specifically about some of the changes that we see with regular mindfulness practice in the brain. Mindfulness in the work setting has been shown to improve stress and anxiety, job performance and satisfaction, problem-solving, decision-making, focus and concentration, also work relationships. And in a moment, when I talk about the changes in the brain, you'll see that there are some positive changes in the prefrontal cortex, the part of our brain that makes us wiser than all the other animals. And that's part of the area of the brain that's involved in these tasks of decision-making, problem-solving, focus, and concentration. And initially, some of the research that was done on looking at the brain and mindfulness was done on Buddhist monks, and their brains were imaged and compared to normal controls. And what was found was that their brains were different. And that may or may not be surprising, but they were different in unique ways. And one of the kind of very fascinating areas that was different was that there was greater volume in the prefrontal cortex. So again, that area of the brain that's involved in our executive functioning skills, and also in the insula that's involved in our self-awareness and perception. And then a bit more recently, such as this review, it was done in 2016, that looked at imaging data involved in mindfulness-based stress reduction, which is a course that I'll talk about in a moment, that even after 8 weeks of consistent mindfulness practice, we see some brain changes similar to what we see in long-term meditators, which is pretty fascinating in my opinion. And based on this particular review, what did they see? They saw studies showed increased activity in the prefrontal cortex after 8 weeks of this MBSR course, increased activity, some increased volume in the hippocampus, these positive changes in the insula, cingulate cortex, and in the amygdala, that little part of the brain that's involved in the fight or flight response, decreased activity and earlier deactivation to emotional stimuli. So this course, you may have heard of it before, based on the work by Jon Kabat-Zinn, and this book, Full Catastrophe Living, is an 8-week course where we meet 2.5 hours each week, a full day silent retreat and home practice with guided meditations. During the course, we learn a variety of meditation techniques, bringing attention to the breath, bodily sensations, as well as ways to bring mindfulness to daily life activities such as walking, communicating, eating. This is a course I teach at Hopkins for patients as well as faculty and staff, and have, after COVID, also began teaching a virtual option, which was a bit truncated, an hour and a half for 6 weeks, sometimes 8 weeks. It's a fabulous course if you're able to take it at some point, and I will provide some resources for you in that regard. So just some brief tools in terms of ways you can integrate mindfulness into your day-to-day. You know, some people will leave and might use one of these tools or a couple of them, and that can be effective and helpful. Some people might leave and really latch onto this and want to take the course. So both are options. But you can just pause throughout the day and take a few deep breaths. And you can think of this as kind of a little mini reset on that stress response. You can bring attention to your senses. So our senses always reside in the present moment. Our thoughts don't. And so a way to ground ourselves back in the present, especially if you notice you're getting caught up in those stories, catastrophic thinking, just come back to some of your senses. Beginning to incorporate pauses when you transition to a new task before picking up your phone. These are just little ways to integrate those breaks where we're not running on autopilot. and labeling our emotions. So we have this saying that if you can name it, you can tame it. And so just dropping in, what am I feeling right now? Okay, sadness, anxiety, frustration, irritability. Just labeling that allows us to get a little bit of space from that experience and not get swept away in it at times. And then, as I mentioned, beginning to catch yourself when you're in that autopilot mode. One of my favorite tools is to drop the story in the context of a stressful event. So state the facts of what's happened. It could be, of course, we have those extreme examples, but it could be something like I'm running late to a meeting. My Zoom isn't connecting. Some of these daily stressors. Okay, state that fact and then notice those add-on thoughts that take you away. What if it doesn't connect? What if I don't show up for this? Oh, I'm terrible at everything. Just that cycle of negative thoughts. Just come back to the facts. I'm running behind. This is just another way to kind of ground yourself in the that you can practice throughout the day. It just takes a minute or two, but the 5, 4, 3, 2, 1 practice of noticing some things you see, feel, hear, smell, and taste. Again, dropping into the body, distancing ourselves a little bit from the thoughts, even if momentarily. And so if you'd like to begin to incorporate mindfulness into your day or formal meditation practice, just a few tips and tools. So start small. So I don't expect anyone here to leave and sit down and meditate for an hour a day. I think that would be excessive and challenging, but start small. When I started with a minute a day. And then the next week I added, I don't know, a few more minutes, 5 minutes, and then just built from there. It's nice to schedule it into the day because this is the first thing that you can take off your calendar easily and not do. Like people think, oh, well, I'm just not doing anything. I'm not being productive, especially those of us who are in this field and tend to be productive, self-driven individuals, but scheduling it and actually doing it, even if it's a minute a day, and then anticipating challenges of, okay, well, where can I find time? Guilt if you don't do it, this tendency to perfectionistic, that I either meditate 20 minutes or I don't do it at all. Having some sort of buddy, meditation buddy that you can text, I did my meditation for today. And this can all apply to any wellness activity, of course. And then bringing a little bit of self-compassion to yourself that, again, we tend not to have for ourselves, that we have extensively for others, but not necessarily for ourselves. Some resources, and again, I believe this is recorded, so you'll see all these. I'm happy for Wendy to share the slides, but and on the next slide, I have a QR code and a link for the mindfulness program, which basically it's a website that my department helped me put together that has a lot of my meditations I recorded, resources such as books and research and anything you want to look at. It's the website's pretty new, so it's still a work in progress. So it's not fully developed, but it has a lot of the basics there. I do not have yet a online recorded version of my MBSR course, but hope to have that at some point. But for the time being, University of Massachusetts, their mindfulness program has an online live course as well as likely a pre-recorded one. You can also just contact your psychological resources at your institution and see if they offer. Many of them do offer MBSR, but they may not be well advertised. So again, here's the QR code. You can scan, or if you just Google Johns Hopkins Mindfulness Program, this will come up. And I think this is my last slide, or second to last, but this was just a faculty member who came through on our courses, and I thought what she shared was really powerful. And so I like to share it in my slides. I was surprised by the impact an intentional practice had on my life. 6 months prior, I was ready to walk away from the career I had spent years working towards because of the emotional volatility and stress I was feeling. This course opened up a new pathway that not only allowed me to continue my work, but actually thrive professionally. The mindfulness impacted all aspects of my life and has had a persistent effect on my happiness and my ability to handle new stress. turning towards my emotions was a new concept for me and truly changed the way I interact with the world. And this is kind of, I hear this a lot. This is partly relates to my own experience of you develop, as Dr. Everly used the term resilience, an ability to be with stressful situations, and that we can't eliminate stress, but can we look at it from a different perspective? Can we kind of fill our tanks so that we have more to give and to be present in the face of stressors? Yep, but my last slide. So thank you. I'll stop my share.
Thank you so very much. And thank you both for your presentations. They seem to interact and support each other very well. So I'll just launch into the Q&A portion with the very first question is, can you both speak to your experience and perspectives on how thinking about community care skills like PFA and self-care skills like MBSR or mindfulness-based stress reduction intersect, and how do they support one another? And especially if it happens to, you have any examples from academic spaces. Dr. Everly, maybe you can touch on that first.
Well, I think, as I mentioned, and Neda, thank you for reiterating, PFA is one tool in a toolbox, and mindfulness is another tool. I think they are potentially equally powerful. One is a way of facilitating improvement, resilience, empowerment in somebody else. The other is helping yourself. We know that we are our most valuable resource. We've chosen healthcare as a profession. Our goal is to help others, but too often we forget to help ourselves. And one of the things that I saw in COVID, which was actually my third pandemic, I was in Hong Kong for SARS, Singapore for H1N1, and now COVID, and I saw it in all three places. We were more than willing to almost sacrifice our psychological well-being to help others, because that's kind of what we signed up for. But we forgot in that equation, the best way to help somebody else is to take care of yourself first. And I think that the mindfulness and related techniques are just remarkably powerful techniques. We've actually, I'll add this to the research. We've just completed a study where we looked at the practice 10 minutes a day of diaphragmatic breathing, and minimum of 4 days a week, preferably 7 days a week, but we knew we couldn't get 7, so we were happy with 4. And we followed people for the training, I should say, is 6 weeks. But what we did is we assessed the activity of the amygdala on pre-test and post-test. And the assessment was not a static assessment, it was a challenge assessment. And we wanted to see if this practice would dampen overreactivity in the amygdala. And that's exactly what we saw. When I was an intern many years ago, I routinely taught people mindfulness and breathing techniques. And my patients would come in with the most perplexing question. And yet I heard it so many times. They said, I'm really worried. And I said, what? I said, are the practices not going well? She said, well, I'm not sure whether they're going well or not. So what do you mean? Well, the things that used to bother me don't bother me anymore. Is that a problem? And at first I was taken aback by it. So anyway, I don't want to opine any further, but I'll switch it back to Neda.
I love that.
Yeah, I completely agree with everything that Dr. Evelyn said. The only thing I would add is that the mindfulness practices can be extremely helpful for individuals when you are providing the PFA concepts, of course. And as I mentioned, I use the term it's a muscle we're building, and so I think it's helpful to start today with that. We will all be confronted with stressors, maybe not all with some of the disasters that Dr. Everly shared, although most of us have at least been through a pandemic. And this is something that allows us to have the resilience to confront those situations in a different way, but it takes practice. So if you are in the face of a crisis, the wise thing is probably not to sit and start meditating on that experience. And that's the art and science of bringing the mindfulness practices together of what do I need right now and how do I use the tools that I have.
Thank you both for those answers and examples. Does anybody have questions in the chat, or you can again send them to me privately if you'd like me to read them anonymously, or if you'd like to put up your hand, I'll be able to notice that and call on you, and you can unmute and ask the question out loud. So while we wait for hands to go up or questions to come in, a follow-up question that is very, very specifically related to Dragonfly and the people that we serve. So we serve academics, and by that we mean graduate and professional students, postdocs and residents, faculty, of course, also the academic staff, and we do serve and have volunteers that are consider themselves academic adjacent. So maybe people with these advanced degrees, or they had spent time in academic spaces for quite some time, are now in industry or nonprofits or government or different kinds of sectors, but still identify with this culture that we have. And there's a huge amount of base level stress for academics, no matter where you are in your career, different stressors at different levels, of course. But there are also periodic, very high level stresses that sometimes are very unpredictable, like the COVID pandemic or current events. So can maybe each of you speak a little bit about how predictable and unpredictable stress can affect individuals, especially in the academic environment, and how you could see PFA and NBSR helping?
Neda, why don't you go ahead?
Sure. So predictable stress, something we can plan for, I think, can be adaptive, right? So we know I have this project due, let me plan and get ready for it. And so that can build resilience, because then we know what we need, how to approach those tasks. Unpredictable stress can over time cause some of those chronic health issues that we talked about. And so, how do we work with that? I guess there are different ways, and I'd love to hear, Dr. Everly's perspective. One thing I always ask people is, well, what is in your control? Right now, the administration, the funding, those aspects may not be, but what is in your control? Can you join an organization such as Dragonfly that's promoting well-being and wellness? And then if you get caught up in worries about the things that aren't in control, first and foremost, just note those worries. And then this is where we get into the cognitive behavioral therapy, or at least this is how I might approach it, is in addition to using the mindfulness tools to come back to the present, say, okay, well, these are the things I can do now. This is what I can work on. Yes, the stress is there. Also, there are a couple of ways to work with the thoughts. Okay, well, if this were to happen, how would I cope with this? And so really going to the extreme sometimes, okay, and tell me what happens next with the catastrophic thinking, and helping people figure out how to cope with unpredictable fears if they're spending a lot of time thinking about them prior to their onset.
We don't like uncertainty. Human beings don't like uncertainty. This may sound like a bit of a stretch, but work with me. I would assert that the stock market is a wonderful psychological gauge for how a country, it doesn't have to be the Dow Jones, it could be a stock market anywhere, how a community is thinking optimistically or pessimistically. And what if you study the stock market, my first 2 degrees were in business, so I did. I realized the stock market went up or down. The correlation was very low with actual financial events. It was very high with anticipated financial events. And the market hates uncertainty. So hold that thought at the community level. Now we flash back to Geoffrey Gray's work at the University of London. Annette, I'm sure you've read his work. He took a look and wrote, I'm not sure how you write a 500-page book on the hippocampus, but by golly, he did. And it reflected a revelation. He called the hippocampus the great comparator. And he said the great comparator was the brain has an expectation. The hippocampus says, okay, that's your expectation. Now let's see what reality says. So it constantly compares expectation with what is now perceived. When they are concordant, no problem. When expectation and reality diverge, the hippocampus lights up on a PET scan like a Christmas tree. And that is noteworthy because one of the things that the hippocampus is replete with are what's called BZ receptors, benzodiazepine receptors, which is highly correlated with anxiety. So we don't like anxiety at a biological level. We don't like it. I'm sorry, we don't like uncertainty at a biological level for the individual. We don't like it at the community level. We don't like it at the economic level. Now, things are sounding pretty gloomy at this point, but wait, there is hope. And I think, Neda, you did a marvelous job in your presentation. Thank you. I so enjoyed it.
Thank you.
Especially with the notion of cognitive therapy. But when we're talking to a non-professional audience or an audience that's very professional, but just not in psychology or psychiatry, let's not call it cognitive behavior therapy because I think that scares people. Let's go back to what its origins really were. And its origins, if you think of the birth of psychology, I mean, when was psychology born? Late 1800s. So what was it before that? It was called philosophy, or at least one arm of philosophy. And if we go back and find the roots for cognitive and cognitive behavior therapy, they fall right on the doorstep of the Stoic philosophers of Sentium and other places. So we're talking about Epictetus. If you want to read one of the best little books on how to deal with uncertainty, it's a book on Stoicism, and it's I think it's called Your Daily Stoic, and there are 365 entries, one for each day. But we reflect back on something that I think is quite powerful, which is this notion, and Neda, you said it again beautifully, control what you can, cope with the rest. And remember, the only thing you really have control over is how you react to the world as it unfolds before you. Those are the Anglicanized words of Marcus Aurelius, actually. So I think it's, I'm also a fan, I'm a fan of the Stoic philosophers. I'm also a fan of the great American philosopher, Charles Schulz. And I have a cartoon by him, and it's Charlie Brown and his dog Snoopy sitting on a dock. And Charlie Brown says to Snoopy, well, Snoopy, you only live once. Snoopy says, no, Charlie Brown, you only die once. You live every day.
Mm-hmm.
Thank you both
Love
for
it.
those deep reflections. I love how this conversation is going. But I'm curious if there are any questions that people want to ask out loud. Please use the tool at the bottom. I believe it's under the React button. You can click it and then raise your hand, and we can call on you. But we did get a private message, and somebody asked very specifically, being an academic and being on campus, what are the ways that we could bring these programs or trainings to our campuses? What are the effective strategies or methods? Obviously, we're sharing the links in the chat, and we'll share them on the video and the website to allow people to access the resources that you're talking about that are freely available. So they can pursue those themselves. But if they wanted to have a more concerted effort or bring these to their campus, what are your recommendations there? Or what have you seen work?
Neda, any thoughts?
Yeah. So if you have a mindfulness champion at your institution and they have become more and more popular, somebody who has some expertise in it is perhaps even certified in training these, reach out to that person. I mean, one thing I do is I go to different departments in our institution and share some of the resources. What is this? You can find pre-recorded talks and share, such as this one, and share them with in a group setting. And sometimes you have to be creative. Like I've worked with some neuroscientists at Hopkins, and they're a little reticent to kind of jump on the mindfulness bandwagon at times. But one way we worked with it is we had a journal club for a period of time focusing on some of these articles of the neuroscience behind mindfulness. And that was just kind of an introduction to, what is the science here? And then can I buy into it? And then how do we start practicing? But then offering little opportunities for people to come together. And again, if you don't have a mindfulness person, play a recording, find a recording, get a group of people together and play it. And all of that is effective in starting to plant the seeds for these practices and grow them once you have a better opportunity, a better understanding of what your specific university or population is open to and would need.
I think there are a lot of, just to echo what you're saying, there are a lot of opportunities, asynchronous programs. They're generally very short, an hour, 2 hours. I actually developed an asynchronous program for the International Critical Incident Stress Foundation during COVID, and it's on uncertainty. The whole program is just on uncertainty. I think it's an hour, 2 hours, something like that. You can look at their website. I'm not sure it's still available, but it's icisf.org. The other ways are just go look at trainings. Again, going to the International Critical Incident Stress Foundation offers Zoom trainings. People can sign up a couple of times a month. And there are many, many other organizations which I'm sure offer trainings. You can do them by onesies and twosies, or you can probably do speakers bureaus and contact those organizations, and they'll provide you with a speaker on whatever topics. But I think I like what Neda said about finding a champion. Somewhere on campus, there will be somebody who says, yeah, I want to get behind this.
Nice, very practical. Wonderful. Graciela, you have your hand up, please. What's your question?
Yes, thank you both. I very much appreciated your presentations, took some notes and hints. I had a specific question regarding the guiding principles of 3 contacts that you spoke about. I think that is definitely, with respect to community, very important. In this current state, especially undergraduates and graduate students often find themselves with no community. And it's not uncommon. And under the current administrative activities, it's even worse with respect to many students that are foreign, or many students that of certain demographic groups may not have as many contacts and or trust, and if anything, increase their fear of contacting people. In this current situation, in this situation of not being able to trust and or make contacts, what are some alternatives in trying to provide that and trying to fill that part of the guiding principles?
I think, let me offer just a couple of thoughts and I'll turn it over to Neda, but I am concerned, I'm very concerned about what we'll call, or what I will call, the loneliness epidemic, which is certainly being fueled by social media issues, but that's a whole nother discussion.
That's all together, especially in that generation, it makes it even, it confounds it. So please.
Yeah, I agree. If you believe the surveys from the American Psychological Association, they would say Generation Z and after are the loneliest generations that we've seen, and the most depressed and the most anxious. When asked Generation Z how many close friends they had, 27% of them said none.
Correct.
And then I think, Graciela, you've updated us correctly with the current environment, which does not always support the idea of reaching out. So one thing that I've seen, two things, a two-prong approach. I do believe in self-empowerment. I believe in looking inside, and there is the power of introspection, if you will. There's a book called Lodestar, Lodestar. It's a national bestseller by Jim McCann. And in the spirit of full disclosure, I happen to be co-author on it. But what we did is we took a look at the best-selling self-help books for 100 years, literally. And we read them, and we extracted only those that had a solid scientific basis. And we then put them in this little general, it's not a textbook, it's a general trade book. Recommendations. One of them, one chapter spends a lot of time on building networks. When it comes to mental health, in many ways, it's whom you know, whom you know, whom you know. Kind of like real estate, it's location, location, location. One of the things we did find, Graciela, during the COVID pandemic, and some of you will appreciate this, in the first 9 months of the COVID pandemic, I did 142 grand rounds in over 20 countries. And it was exclusively with hospitals whose staff were burning out and vicariously traumatized. And one of the things that we saw working very effectively was support groups. We'll call them informal support groups. And that was a way of creating an on-the-spot community. And I would recommend that. Neda, what are your thoughts?
I think that, yeah, really hits the nail on the head. It's so hard. I think the loneliness epidemic, and I think also, social media is a blessing and a curse in that you can connect in some ways virtually, but it doesn't often give that same level of connection. And I agree that, like, bringing people together on campus, offering, sometimes it just takes somebody to offer this opportunity to get together. With my mindfulness courses, I think it's so interesting to me that just bringing people together, if I teach no skills whatsoever, just the state of bringing these individuals together with similar issues is so powerful and therapeutic that I'd like to, study the role that plays in the actual impact of the course. So I think, you can only start small and perhaps with your institution, but putting it out there like you do with the mindfulness. We have this opportunity. We have this group, this support group, and seeing who comes and then spreading the word. But I totally understand, Graciela, it's not an easy thing to do.
What I would also add is those support groups can be done virtually over Zoom. Because one of the things we were concerned with COVID was bringing people together and then having it exposed to the virus.
Yeah.
So and again, the nice thing about Zoom, if people don't want to turn their cameras on, they don't have to.
And in that regard, then you have access internationally to recruit people. So
So
yeah.
it's a safer space for them so that they don't have to feel fearful of being out in clinics or
Yeah. And somebody here, they left but had a funny like a cute little avatar as their as their picture. So yeah, you can kind of be anonymous there, but still benefit from some of the discussion.
The only caution I would offer is that there needs to be ground rules. There is some of you may be familiar with an online magazine called Psychology Today. It gets several million views a day, so it's quite remarkable. But they had to suspend their reader comments section because of what was perceived as vitriol. So yeah, I think ground rules, constructive ground rules, are a key to running effective support groups of any kind.
One of which I'll share is, and this is a major feature of what we promote and support and try to build out, both things that we can offer as well as education for you to build your own within your own communities on your own campuses, is peer support, peer networking. So at Dragonfly, we have restarted our Dragonfly cafes. So you can go to this website, learn more about it, and share this with others. It is free and open to all academics from anywhere. And so that's the international and virtual version of things. But we also have some educational pieces on building your own peer network. And so those are available on our YouTube page. And in addition to that, you can also do things that are not just a single peer, but kind of embed mentorship into it. So academic family peer mentoring is a system that I was engaged in going back as far as 2006. I got exposed to a model like that where juniors and seniors within an undergrad class or more senior graduate students would get matched with, or there would be a kind of matching period for people to find like-minded mentors that were a little further along in the career path, but were still seen as peers and understood all the nuances of things. So that's another way to build these small networks and then even build out larger networks from those formally or informally. So all of those are good things to do. We are at the end of the 90 minutes, but there was a question that somebody asked, and I do want Dr. Gould to be able to answer it. So someone asked if there was advice for someone, and actually both of you could chime in here, is if someone is dealing with an anxiety or panic attack, are the skills from PFA or mindfulness-based stress reduction skills useful and applicable, and how would you help someone who might?
It's challenging. So panic attacks can happen. They can happen in the context of any anxiety disorder, or can be their own anxiety disorder, and we call it a disorder when those symptoms begin to interfere with your quality of life or functioning. And the mindfulness, yes, as a longer term tool, absolutely can help, like Dr. Everly was saying, kind of turn off that the amygdala a little bit, the stress response. In the acute setting, panic attacks are very distressing for people and hard for me to say, let's turn towards that. Let's notice your shortness of breath and let's notice, the tingling or dizziness or whatever you're experiencing. And so that might not be the best short-term way. But when you're not experiencing a panic attack, that's when you can build that muscle, practicing relaxation, practicing mindfulness. With panic attack and panic disorders, the treatment is a type of cognitive behavioral therapy. An effective treatment is cognitive behavioral therapy, and specifically exposure therapy, where you learn to be with those experiences, those physical sensations and the thoughts that accompany them, and change some of those thoughts that are to more effective strategies. So in that case, I'd say looking for a cognitive behavioral therapist is helpful. I'm happy to put my email in the chat as well. So if you have questions that we did not have time to answer, you're welcome to send me an email.
I would also recommend in the very acute phase, diaphragmatic breathing, very simple pattern breathing, 2 stomach breaths followed by 4 to 5 regular breaths, followed by 2 stomach breaths, followed by 4 to 5 stomach breaths. I have seen that technique used. I used to specialize in treating panic attacks, and you'd be surprised how